Hello everyone, my name is Елена Levkovich. I'm the 5th year student pediatric faculty of Belarusian State Medical University. I want to present you my report, the result of treatment of the ureteric strictures in kidney allograft. Kidney transplantation is the optimal method of renal replacement therapy in patients with chronic kidney disease, which significantly improves the quality of life. According to the literature and clinical data, the incidence of ureteral strictures in kidney transplant recipients is from 3 to 12%, what makes this complication one of the most frequent. The main methods of correction of this type of complications to date remains the performance of ureteral system anastomosis, but there are methods of minimally invasive treatment in the form of balloon dilatation and ureteral stenting under X-ray control, which have a comparable effectiveness in correcting ureteral strictures of the graft with an undeniably lighter course of the rehabilitation period. Our goal is to evaluate the treatment results of strictures in kidney graft at Minsk Scientific and Practical Center for Surgery, Transplantation and Hematology. Objectives are to compare the frequency of complication of various methods, to evaluate the function of grafts, to analyze the survival and duration of graft functioning, to compare the effectiveness of surgical interventions. Materials and methods. We performed a retrospective cohort single-center comparative study in two groups involving 62 patients who underwent kidney transplantation and have a ureteral stricture development of graft. Two research groups have been formed. The first group included the patient with balloon dilatation with ureteral stenting treatment. The second group included patients who underwent ureteral system anastomosis using intravesical technique. Various stents were used to correct the stricture of the patients of the main group. The main characteristics of the stents were diameter and length. On this slide, you can see stages of installations of a nitinol stent graft through percutaneous nephrostomy in a renal transplant, and the structure of a permanent ureteral stent. It is shown the intravesical technique used as the surgical treatment of graft ureteral stricture. The table provides information about the demographic characteristics of the study groups. The following factors were statistically significant: the time elapsed from kidney transplantation to stricture correction surgery, as well as the type of stricture, primary or secondary. In the course of the study, a comparative analysis of the number of leukocytes and erythrocytes in the microscopy of urine sediment, as well as the general urine test, which was performed using an automatic analyzer, was carried out. The number of leukocytes determined by urine microscopy didn't have a huge differences. The number of leukocytes in the automatic urine test had statistical differences among the two groups, which is reflected in the graph. The slide shows a comparison of the number of erythrocytes determined by urine microscopy. According to the findings, the results didn't differ statistically. The automatic urine analysis revealed significant differences in the number of red blood cells. As the conclusion, the analysis revealed statistically significant differences between the groups in occurrence of urinary tract infections and hematuria according to automatic urine test. Urinary tract infections was found in 10 out of 27 patients from the group with ureteral stenting, and in 12 out of 35 patients after compliance of free ureteral system anastomosis. Bacteriuria was detected in 9 out of 27 cases after ureteral stenting and in 11 out of 35 cases after open surgery. Hematuria was laboratory confirmed in 15 out of 27 patients after treatment using a minimally invasive technique and in 16 out of 35 study participants who underwent open surgery. we determined the dynamics of the serum creatinine level to compare the functional state of allograft. Measurements were carried out a day after the interventions and after 1, 3, and 12 months. Here you can see the numerical values of the indicator in two groups. The slide shows the dynamic of serum creatinine levels after surgical correction of ureteric stricture in the study groups after the intervention and after 1, 3, and 12 months. In both groups, the creatinine level began to decrease gradually after surgery. Comparison of graft survival. At the time of the study, 4 of 25 allografts of patients who underwent minimally invasive intervention and 5 out of 35 transplants examined after ureteral system anastomosis were lost. A Kaplan-Meier survival analysis and estimate according to Cox regression were performed. The Kaplan-Meier analysis is shown on the graph. 1 year survival rate was 92% in the stenting group and 91% in the open surgery group. The 5-year survival rate was at the level of 83% and 88% in the first and in the second groups. During the study, it was found that the chosen methods of correction of ureteral stricture doesn't affect the duration of graft functioning. Comparison of the effectiveness of treatment methods. In the long-term periods, 16 out of 27 study participants from the stenting group and 13 out of 35 participants from the ureteral system anastomosis group required repeated surgical interventions. The results of the study showed that the duration of hospitalization differed significantly among the two methods of treatment. The main conclusions are: restoration of graft function was achieved by performing both minimally invasive and standard correction techniques. The graft survival rate in the two groups of comparison had no statistically significant differences. The length of hospital stay is significantly longer after the ureteral system anastomosis, which increases the cost of treatment of this category of patients and reduces their rehabilitation potential. Thank you for your attention.